All right, well, good morning, bonjour. Everybody have a good evening last night? It's a very excited crowd. I can feel it. It's palpable. Monty said make sure to use the whole stage, so I'm going to walk up here. Welcome, everybody, to the dialysis session this morning. I'm excited to have everybody here. I'm sure we'll see people file in as they shake off the champagne from last night, as Alex mentioned. Our first speaker really needs no introduction. Dr. Bart Dolmatch is going to speak to us a little bit yesterday, if you heard the exciting debate between Dr. Wasse and him about the future of percutaneous fistulas. So, Bart, we're excited to hear what you have to mention today, and then we'll have room for questions afterwards. Welcome.
Great. Thank you, Stephen. It's great. It's a small but an interested crowd, I can tell. The title of the talk I was given was something like Percutaneous Fistula is Not Dead, but at a meeting like this, I don't think you want to put dead in any title for any talk. So I'm going to talk about the feasibility study on the Venous 2 trial. This is a second-generation percutaneous fistula device, and I'll show you a little bit more about it in just a moment. My disclosures, I do have a consultancy, and I was the PI, the global PI for the Venous 2 study. Well, there are unmet needs for creating hemodialysis access. I'm not going to spend too much time on this. I think we know that a very minority of patients really start hemodialysis with a working fistula. Oftentimes it's a catheter. More than about 80% in the US start with a catheter, with or without a maturing fistula. And this catheter dwell time is a problem, as well as the access towards a surgical creation of fistulas. This is the Velocity device. It's a percutaneous fenestrated covered stent. I'll show you the two different sizes in just a minute. The thought is that this would avoid the competitive deep venous flow that's created with the current first-generation percutaneous fistula devices. It would avoid anastomotic and perforating vein stenosis because the covered stent supports the anastomosis and the perforating vein. It does not require any kind of thermal energy. It's actually just an implant, as you'll see. It has a certain diameter of the device, so it limits the amount of flow, so you don't typically get these super high flow fistulae. And the procedure times in Venous 2 was just under 20 minutes, as I'll show you. These are the two devices. You can see the fenestration on the bottom of the device. Let's see if this pointer works. Oh, it does. Great. So here's the fenestration. This is the part that goes into the artery, and this is the part that extends into the perforating vein. So you do have to have the right anatomy for making a percutaneous fistula, and it's very much like the ellipsis procedure, so I'll show you in just a minute. The two different devices were based upon the size of the radial artery and the perforating vein. Here's a little video that will take you through what happens, similar to doing an ellipsis procedure. There's a puncture into the vein just above where the perforating vein drains, and then you go through the vein into the radial artery, pass a wire. You'll notice there's no sheath. The device goes in, deploying the venous side first, as you'll see here. Pull back, the delivery system catches the arterial wall. Then by retracting the little thumb switch, deploy the venous side, push forward, the arterial side comes out, recapture, turn the device, and then you're done. And this is why this is an under 20-minute procedure for most of the operators. There's no drive units, there's no thermal energy, no RF or anything like that. This is from the Venous 1 study. You can see what this looks like after an implant, where you have this communication from the radial artery through the fenestration and into the outflow perforating vein, as well as retrograde flow, as you can see here, that comes up the retrograde radial artery into the device. The Venous 2 study was conducted at 5 different sites. The primary endpoints were physiologic maturation and serious adverse device events, and secondary endpoints include technical success, time to cannulation, functional maturation, catheter days, and cumulative patency. I don't have time to go through all of this, but I'll show you what we have. One of the interesting things about the device is that the artery and vein can be up to 3 millimeters apart, so it does give you a little more latitude as far as creating a percutaneous fistula. So the 23 subjects that were enrolled in the Venous 2 feasibility trial, as you can see here, about 54 years old, 91% males, and the usual number of comorbidities, diabetes in about 2/3, almost everybody had hypertension. Patients were started on aspirin and Plavix for 7 days, and the average time on a central venous catheter was almost 8 months. I'd also say that patients were included if they were heading towards dialysis but not yet requiring dialysis as well. This is just some parameters as far as the size of the artery and so forth. I won't spend much time on that. Here's what we found out to 3 months. Access flow started at just under 1,000 milliliters per minute, went up to about 1,500 or so. Seems to be over the next 3 months after. We'll present that data in a few months, but it seems to be leveling off because of the aperture, the size of the device, and the cephalic vein diameter. Initially, pre-procedure was just under 4 millimeters. Right after the procedure, went up to just above 5 on average, and then got up to about 6 to 7 millimeters for most patients. The physiologic maturation was defined as flow of greater than 500 milliliters per minute, diameter of 5 millimeters for the cephalic vein. So you can see that 96% reached this endpoint by 6 weeks. No coil embolization of the deep veins. And time to cannulation was an average of about 63 days. No special dialysis unit training, although in many cases, as I'll show you, there was either coiling or ligation of competitive flow into the basilic system. This is what one of the patients looks like with a dual needle cannulation. It looks every bit like a surgical brachiocephalic fistula. Ultrasound typically was done at 3 months in the study and then 6 months for some patients so far, and you can see that the device remained predominantly patent. Histology in an animal model and a pig model, no lumen loss. And I thought I'd show you this. Reinterventions by 3 months occurred in 9 of 23 patients, a total of 16 procedures, but if you see, really, many of the procedures occurred in 5 of the patients. There were 5 patients, and this is so typical for what you see with surgical fistulas as well, where many patients need some dilation of an immature fistula or some other region coiling or ligation of outflow veins. But if you really look at the device, there are only 3 patients that required actually device-related interventions, and one of them was to occlude steel in a patient that had pretty advanced radial and ulnar artery disease. Let me talk about that for just a moment. One patient with distal radial stenosis and ulnar occlusion developed paresthesias from steel, and the device had to be occluded, which was fairly straightforward because it is an implant. You can identify it well, and you can put a plug or a coil right there. One patient thrombosed, but they didn't have any adjunctive heparin during the procedure. It was declotted, and it remained patent throughout the study at this point, and one patient required balloon dilation of the velocity. This is interesting. Patient satisfaction was extremely good. Patients definitely felt that they were satisfied with the result and were very appreciative of the procedure, which was either definitely true or mostly true. And there are some future directions that I'll just briefly mention. 6-month results will be presented at the SIR meeting this coming spring. And then there's Venous 3 that's already been initiated, which is FDA has given the IDE approval. The trial approval for 126 patients at 14 sites. The first patient enrolled at towards the end of October, and 6 implants scheduled for this week. So there's a lot of action and should be a lot of results coming down the road. In summary, the early results validate the mission, which is a simple method for creating percutaneous fistulas with consistent physiology across all operators and study sites, flow where it matters, that's the superficial venous system, not the deep system, and preservation of physical exam cues in the study, sometimes related to occlusion, ligation, or reduction of flow into the basilic venous system. Thank you very much. Open for questions. Thank you.
Thank you, Bart. That was wonderful. While I look to see if there's any questions from the audience, do you have any concern about having a stent in the radial artery long term? Is there any worry about potential thrombosis or erosion or anything like that?
Yeah, not been seen. It's remember, this is kind of in the radial. It's in the deep system, and it goes to the perforating vein. And I'm a total advocate for putting implantable devices in everybody. So, no, I'm just kidding. But with that said, I think that if we can really get this, if this really turns in the large Venous 3 study to show a high rate of percutaneous fistula functional maturity without lots of procedures to treat the anastomosis or the perforating vein and deal with deep venous flow, then I think it's a total winner.
Yeah. Any questions from the audience? Mani?
More of a comment than a question.
Yeah.
So I think this next iteration, we had our debate yesterday, if you weren't there, was about some of the challenges around the first generation endovascular fistulas. I think this one goes a long way in addressing the majority of the reintervention pieces. But one of the things that still remains as a challenge, I think, is to ensure that the cannulation segment is actually cannulatable, and the target vessels are cannulatable. Do you see this as being something, this next iteration, do you see this as being something that, for the most part, addresses that problem, or do you still anticipate that there'll be a need for superficialization, additional training in the dialysis units to ensure people are familiar and comfortable with the dual outflow cannulation? What are some of the pieces about cannulation that you think will be improved upon?
Well, I thought you said it was a comment, not a question, but I'm happy to answer the question.
Well, I pivoted.
Okay, got it. No worries. So I do think that, we have to change our mindset from saying we're going to get this dual outflow, uncannulatable fistula to saying we have to make a fistula that when the patient goes to the dialysis unit is recognized to be a fistula that be cannulated, and whatever that takes, which in a number of the patients required median basilic vein ligation or coiling or something, so that the cephalic vein would be like a monofistula. Now, that's contrary to what some people would like to have, but I think that's so necessary for the dialysis unit so that there's a high success for cannulation, as you mentioned yesterday, which is really the stopping point for so many patients with a percutaneous fistula, where nobody can really tell they have a fistula and it can't be cannulated. So making it a palpable fistula with a thrill, where somebody says, I can cannulate that, is really important.
Excellent.
All right. Thank you very much.
Well, very good.
Stephen, I think you're going to have to introduce the next speaker.
Yeah, well, I'll introduce myself. I'm Stephen Homan, vascular surgeon from Dallas, Texas.
Oh, you're the next speaker.
Yes, I am. So thank you. I'm excited to be here. I get the interesting topic of how to actually put the accesses where we want them to be. And I think this is one of the really key things that I'm sure we'll have a lot of opinions on how everybody does it, and I'd love to hear everybody's take on it as well. So with that being said, we'll get started. I always love this one. They called me on a Friday afternoon and said, I think we may have a problem with this fistula. And I said, oh, what makes you think so? They're like, it just doesn't look right. I said, can you send them over to the office? And this is what showed up. So I'm not sure if it's the same here in Paris, but that's always around 4 p.m. on a Friday afternoon. So what's the problem? Oftentimes we focus on patency, but it's rather usability. I think one of the really interesting things about a dialysis access is one of the few things we actually create. So you don't create a carotid endarterectomy. You don't necessarily create an endo AV fistula or endo aneurysm repair, but you definitely create a fistula. So at the end of the day, though, it's not really the patient that uses it. It's actually the tech. So we actually have to have something that's very usable. So the twos, you don't want it too deep, you don't want it too small. Whether it's the rule of sixes or rule of fives, it doesn't really matter. The point is, can you actually use it? So if it's too deep, what can we do? We can raise it to the surface, we can remove the fat. We could add a cannulation device called VenaSure. I'll mention that, which I'm the national PI for. We'll bring that up. But at the end of the day, you have to have an access that's usable. And I think that was one of the big things we talked about with the percutaneous fistulas that we really struggle with. So I always tell my patients we want a long runway. So we want to land at Charles de Gaulle, not on an aircraft carrier. So long and straight, make it easy to be used. And it really comes down to the tunneling, the mobilization, and then avoiding kinking. And I'll particularly bring this up with basilic vein to start with. So where to tunnel it, I think we all know about mobilizing the vein adequately so we can have that long segment. But we don't want to leave it on the inside of the arm for a number of reasons. One is the cutaneous nerves can be in the direction. So we really want to tunnel it. I like a hollow tunneler for this one. And in order to bring it through, this is where that perforator comes down that we all see with the endo access. And then bringing the vein into position. Something nice and easy so that way the technicians can use it, get it into position, so our anastomosis. Then you have a nice fistula that lays on the outside of the arm. I think one of the key things I always mention with everybody is we always want people thumbs up. So they're thumbs up positions, that way it's easy to access at the unit, so people don't have to externally rotate their shoulder. Occasionally I'll get somebody referred to me for steel, and it turns out they're actually a positional problem that they're having to rotate their arm. So we want to make sure that it's in a good spot. Also, you want to avoid the median nerve. This was a patient that was referred to me for steel, but it turns out that his graft was stuck to his median nerve. So they hadn't mobilized the vein off of the nerve enough, and as he had that scar tissue, he had loss of function in his 3 fingers. So loop grafts, we'll mention here, this is the one I always like to say. When I place a loop graft, you always want to put it more towards the outside of the arm. That way, as it's flowing counterclockwise, they can use that inner aspect over the biceps. So that way, as the needle goes through the bicep, it's not in that area of the cutaneous nerve, or even if they miss the back wall to get the median nerve, and I'll mention one of those also later here. If the cephalic vein's too deep, of course, we can raise it up, and there's also a device that's a cannulation device called the Venisure that you can see here on the right side of the screen, and it has a area of cannulation, and it also has a metal back wall, so you can't go through the back wall of the vein. Sets up the vein so it can be used reliably without having that potential issue of injuring the back wall. And then here as it's closed up, and then these are the actual cannulation zones in the patient, and this is what the device looks like. Comes in 4 different sizes, and that way they can use it. And then here's a video here of me tunneling. So this is a left arm, and so I've made an incision up the upper part. Most people leave the arm lateral. I always want to lift up the arm, and also if they have tissue on the backside of their arm, this way you can get an idea where it's going to lay ahead of time. Don't just leave the arm supine. You don't want to just create it that way. You want to make sure when you roll it out that you can see where the access points are going to be. Then draw out where we want it to flow. I like to have the arterial inflow come along the medial aspect. I find that easier to declot. So whether it's being done percutaneously or in open fashion, it's easier to enter the artery that way rather than going over the bicep. And here's my tunneler. So when we tunnel with the AV graft, I always like to use the largest head, which is the 10 millimeter one. So that way we're not dragging the graft through. The PTFE actually has holes in it, and if you drag the PTFE too much, you can actually get a serous, or what we call a sweating of the graft, where it can actually leak transudate. So this is one of the harder parts to teach. This is my fellow here that has it, and you can see he kind of gets started here, trying to make that just deep enough that it's not right under the skin, but you also want to be able to pinch an inch over it. So some people tunnel the grafts too deep, and that makes it difficult in order to access. You can see we finally get it through there, and then bring it into position. The last thing I always mention is the grafts are actually elastic, so as you pull them through, so you can watch me pull it through and you can see how much length we have, and then to actually move the arm and give it a moment to allow that to retract, so that way you don't tighten it up underneath there. So you can see as we pull it through, as I was making fun of him, pull harder. And then you can leave a little bit of space there, then actually move the arm around. You can see actually how it kind of will contract. I think many people pull it through too tight on the graft. So give it a moment to not pull it through too tight. Let it relax, and then you can actually see, move the arm around. Make sure you have plenty of room and it's not under any tension. I think those are a couple of the key important things with tunneling of the grafts. Really like the upper arm and the use of that proximal brachial artery to decrease the risk of steel. So you can actually see how that graft is kind of retracted a portion there. A cephalic vein, there's a lot of ways of doing this. I like to make a tunnel laterally and then actually close the fat behind it. This way you'll always know where the fistula lives, which is just lateral to the incision site. I don't like sticking through the incision site for a number of reasons, but this way this is a left arm and you can see the vein then lives just laterally to it would be another way of doing it. Here's a fistula, obviously tortuous, an aneurysmal, aneurysmorrhaphy, close it. Once again, move it towards the outside of where the scar site is. Another patient, access consult, a large arm, high BMI. I think one of the key things on this, she had a previously failed brachiocephalic fistula for a number of years, tunneling the graft, making sure we really get it lateral in the arm so that way she can use it at the dialysis center as she's sitting. Once again, thumbs up. So there they are using it. Another one with a fistula with an aneurysmal area, so jumping around that, giving plenty of room laterally, an early access graft that can be used right away, skip the catheter. This is one of the ones I always like to bring up. So we mentioned using the median cubital vein potentially for access. Patient came to me with complaints of thumb, index, and middle finger discomfort. And when we actually scanned it, they'd been using the median cubital vein, that actually caused a pseudoaneurysm of the brachial artery. So by sticking through it and going through the vein, that actually got in the brachial artery. So that's one of the things on the endofistula, is to make sure that the brachial artery is not exactly posterior to where you're using it. And then here we repaired it from the inside, fixed it up, and allowed them to continue to use the outside. This is the last case, just something not to forget. Hispanic male comes in, had a radiocephalic for a number of years. On his ultrasound, his cephalic vein in the upper arm was occluded, but he had a very good basilic vein on his forearm. So we did a forearm basilic vein transposition. Of course, when you harvest it, it's nice to have the arm actually raised up, so that way you can expose the vein. But then tunneling it laterally to make it easy to use, and then connecting it to the radial artery. So you can see his incision is nicely healed up on the back of his arm. Got a nice, straight, long landing zone there. Worked well. High 2-year patency rates. You can see what it is, primary and secondary patency rates with the brachial basilic versus the forearm basilic. So don't forget to look at the forearm basilic, especially if somebody's had an access for a while. So merci beaucoup. This is a wonderful, I love this stage. I feel very important, like fashion show type thing. So thank you very much. I'm happy to entertain any questions or hear. I know there's a lot of surgeons in the audience probably with preferences of the way they like to do stuff, so I'd love to hear from you too. Thank you.
We're running well ahead. If there are any questions from the audience, as an interventional radiologist, I mean, seeing some of these incisions and some of the manipulations makes me feel like I'm doing a little dance in the park when I do angioplasties.
Well, I love that you showed the least invasive thing possible, and then I showed the most invasive possible. So I knew you would have a question. I was waiting for you.
Hello. Do you have a use of lipectomy?
You know, I don't like lipectomy. Do you do it? Can you give me your thoughts on it?
It was created by Pierre Bourkelot a long time ago, and it's very efficacious, especially for the cephalic vein.
Do you like to do 2 transverse incisions and do the lipectomy in between?
I perform the scar laterally, not in front of the vein.
Yeah, the one thing I like about the incision as far as for the elevation of the vein is that way the technicians can always find it, because I say no matter what, it's always just lateral to the incision site. But lots of different ways to do that. Has anybody done liposuction for it? I'm not as much of a fan of that. I'm just concerned about the injury of the vein with it and that sort of thing. Also, it's nice to get rid of, usually there tends to be 3 lateral branches, as you know, to the cephalic vein, and you can ligate those also. So, Dr. Malios.
Hey, sir.
Efaristo. I learn one word in each language and then just throw it out endlessly.
So now you can learn a second one, parakalo, which is the way to say you're welcome.
Okay, parakalo.
Okay.
Kalimara.
So to second Thierry's question and remark, I don't think lipectomy is a question of liking it or a preference. Sometimes you have to do it because it's a question of whether you're having sufficient length. And I think this is why Pierre Bourkelot and also Tip Jennings are doing it. Because if you don't have enough length and the vein is deep and you have to bring it up, then you either have to do a lipectomy, so essentially bring the skin down, or if you have to redo a superficialization, you have to redo the arterial anastomosis, and then you have much shorter cannulation segment. What's your opinion?
I don't think you need to do that, particularly if you make a longer incision, longitudinal incision in the arm, you definitely have enough of the adipose tissue to bring posteriorly, and I don't like redoing the anastomosis. I like leaving the anastomosis if possible. I don't think you need to do lipectomy. I'd rather raise the vein than lower the skin. I think you still have plenty of room.
But if the vein is, I'll be a bit more clear, perhaps I wasn't clear enough. If the vein is a bit tortuous, you have enough length to bring it up. But if the vein is straight, then if you try to pull it up and bring the fat behind, you're going to stretch it too much.
I think in most cases, especially if you dissect higher up, you're definitely able to get enough. I just did the other day a lady that was 25 millimeters deep, and we were still able to get enough kind of runway to come up and to go back down. Particularly if you use a retractor and you can really get up higher in the arm, you almost always, I've never had it where you can't get enough length. Particularly also when you're doing it that way, you're ligating the side branches. And that tends what I think tense the vein down. When you do the lipectomy, you may or may not necessarily get those. And so I think that buys you enough distance to do it that way. But thank you, Alex.
All right. Oh, one more question.
Oh, Moni. Yes, ma'am.
So I really like your approach to the patient comfort and understanding what the position is of their arm during dialysis. Have you seen your position of the graft result in fewer complications like infiltrations and pseudoaneurysms? Because I would imagine that with that placement, it's easier for the dialysis unit to cannulate it and not make a mistake.
Yes, so Dr. Wase asked if it's better as far as tunneling the graft, if I'd noticed less infiltrations, that sort of thing. I think I do, and in fact, I didn't nobody taught me that except the dialysis nurses. So I went, I first was in practice, I was like, I'm gonna get business, so I'm gonna go out to the dialysis centers and, hi, nice to meet you. They're like, you're the first doctor that's ever come. I'm like, that's either a good thing or a bad thing. And we're walking around the unit, and she goes, let me show you something. She's like, why do you always put the grafts like this? I'm like, well, because that's what we want. She's like, well, could you put it farther on the arm? Because, our patients like to sit like this and, have this. Would you be able to do that? I'm like, yeah, sure, we can do that. And so now, definitely talk about it all the time. I can certainly see a lower risk of kind of aneurysm degeneration, particularly along this medial aspect, because a lot of patients have to rotate their arms so much externally in order to get access there. And so I think the chance of kind of needle disruption or coming loose is significantly lower with that, for sure.
Stephen.
Yes.
Let me.
I hear John Lucas somewhere.
Right here. What Alex said.
Earth down, yes.
I tend to use a lipectomy in those situations where you have important branches that, if you ligate them, turn the fistula more pulsatile. And so sometimes the outflow needs to go through several branches, and if you ligate them, that increases the pressure inside. So a lipectomy allows you to make it cannulatable without sacrificing those important branches.
Yeah, I have to make it controversial because that makes it more interesting. I completely disagree with you. Completely. I like you, but I disagree with you. Because if you need those to maintain your outflow, something's wrong with your outflow. So I think in the vast majority of the time, you don't need those collateral branches, that you can get rid of those, that you should have a nice cephalic arch outflow. So
I recommend also to surgeons to go in the dialysis unit to see the situation and how the fistula or the graft are sticked, because sometimes you see bad mistakes, and the first picture you show is the result of abandonment of the patient by the nephrologist.
I think that's a very good point, and I think most surgeons don't spend any time going to the dialysis center to see the end user of what you've created, which is the person that puts the needle into there. It's very different than other stuff. Robert.
Back to the point from John Lucas.
Yeah.
I think that the importance of keeping the branches, especially for the upper arm cephalic vein, is not to keeping it open, but rather to reduce the risk of cephalic arch or symptomatic cephalic arch issues, because then if you remove all ligatory branches, that pulsatile flow will go into the cephalic arch and eventually you will get issues. I think that's the difference that we have also considering the smaller inflow artery with forearm fistulas, that the forearm cephalic has a lot of branches, and I barely ligate any branch unless it is really important, just to depressurize the whole flow into the outflow conduit.
Yeah, honestly, I think that's a little bit more theoretical, but, this is what's fun about surgery. Everybody has, I like to do it this way, or I like to do it this way. That's the art of it and the daily practice of it. If we all did it the same, it'd be very boring. So.
Okay.
High flow in the brachiocephalic affects the risk of cephalic arch.
High flow in the brachiocephalic increases the risk. Yeah, yes. And you can definitely band it down.
I will insert a controversy to your controversial answer to John Lucas. I think actually what you said is very important, and I take issue with this, because if you have a fistula, like a brachiocephalic fistula, that the cephalic arch is a bit problematic, and finally nature gave the solution through 2 or 3 collaterals, and finally you have a non-pulsatile vessel, which is our target. Why would you go and ligate these branches and then get into a vicious circle of ballooning it, reballooning it, DCBing it, finally stent graft it, and finally being necessary to do a new fistula later on, while you could just do a lipectomy, keep your branches there, and leave the patient in peace.
Well, I mean, I always like to deal with today's problem today, tomorrow's problem tomorrow. I would rather have a nice vein that's superficial and usable and have a theoretical risk of having outflow stenosis than leaving branches and just doing a lipectomy. I don't think, I don't agree with the fact that the collaterals are preserving you from having future issues. I think it's a little bit more than that. And I think a nice straight vein, if you need to do something to the outflow arch, I think that's fine. If you want to ban the inflow, that's fine. But I think raising it up certainly doesn't give you any issue with that.
Well, I think we'll move ahead here. We're still a couple of minutes.
I sense a debate for next year.
No, I suspect that we're going to put you, Alex, John, and maybe Robert all in the fight cage and let you guys just fight it out and see who wins.
Or sit in a ski lift together. Either one.
I'm afraid in that scenario, they don't have a chance against me, yeah?
Well, very good. Thank you, Stephen. And now we have John Lucas from the States. We have people speaking English. We have people speaking French. And then we have John Lucas, who has a specific kind of a dialect here from English. It comes from Mississippi and is a very accomplished access surgeon. John, thanks for being here.
I was given the topic of optimizing AV fistula maturation and when to use a device. These are my conflicts of interest. There are 3 devices that are currently available at time of implant: Velocity, which Dr. Dolmach so eloquently described, self-wrap, and the Vascu device. And I'm going to skip through the Velocity slides since Bart did such a good job outlining that. But I do want to point out that the limitation of flow is probably going to be a very important part of this. I think we're more and more recognizing how deleterious high flow is to both the cardiac issues and to the access circuit itself. And the Venus 3 trial is ongoing, and hopefully in a year or two we'll have some outcomes to that to see how that affects access, maturity, and longevity. The self-wrap is a perivascular wrap. It's bioabsorbable. It's designed to improve maturation, reduce inward growth on the endothelium, promote outward vein dilation by providing a biomechanical support, and it may regulate flow. This was done in animal labs looking at different size pore sizes, and the pore size that's selected was the one that optimized neovascularization. And the device is implanted into the arm at the site of a radiocephalic or brachiocephalic, and then implanted over the vein before the anastomosis is done, and then slid down over the top of the artery and wrapped around. This is a cartoon of a wrapped and a not wrapped fistula. And this shows what they've shown in early studies is that there's much less the intimal hyperplasia compared to the unsupported access. And so they are currently in the middle of enrolling 400 patients in a randomized trial, 1-to-1, using radiocephalics and brachiocephalics. And they're looking at unassisted maturation in 180 days, and they're going to follow up for 36 months. So we await the outcomes of these trials. This is a picture of the device that's implanted in a person, and you can see the pore sizes of the device. And next, I'd like to talk about Vascu, which is a nitinol device. It has a braid and a brace, and then the eyelets that wrap around the artery in order to secure it and prevent any kind of migration. There are multiple studies. Dr. Shavardian has been the author of several of these that shows increased patency and functional use compared to unsupported fistulas, with the Vascu devices, the ones presented in blue. This is my personal data, and I've done a little over 120 Vascu insertions, and you can see it comes in several sizes, and the Vascu device pretty much limits flow. This is the 2 is the smallest device and the 6 is the largest device. And in those where I've implanted it, you can see there's a linear relationship between size and flow, and it maxes out at around 1,100 or 1,200 milliliters per minute on average. If we look at all the vascular devices, I've put in 148, and you can see that that trend continues regardless of the location. What I'd like to show you now is a use of the vascular device that hasn't been described in the literature, because those were brachiocephalics, or proximal radiocephalics, or brachiocephalic fistulas. And I found that it's very useful in a one-stage brachiobasilic transposition. And I've done around 1,400 transpositions, and most of mine were two-stage, over 85% of them, because of my poor results early on with the one-stage. But the vascular device improving the problem with swing segment stenosis and improving the rapidity of vein dilation, I've tried it as a one-stage, and normally my one-stage have been only in those veins that are around 5 millimeters or bigger, and so that's when they've had a forearm graft or forearm fistula and the outflow has already caused to dilate. But using the vascular device, I've gone down to 3 or 3.5 millimeters for a basilic vein. And this is a picture of a vein, and doing it in 2 stages. This is an incision below the elbow where I've got an additional length so that I can swing the vein more anterior, as Dr. Holman pointed out, making it more cannulatable. This is after it's been tunneled through and the device has been placed onto the vein. And this is the anastomosis, and that's what it looks like after it's been implanted. This was actually another patient. There's a radiocephalic, and this is a brachiobasilic, but you can see how it protects the vein as it's curving around. But more importantly, I think it provides external support and eliminates wall tension in the vein. These are the numbers. So my 2-stage brachiobasilic transpositions are a little bit long because some people didn't want their fistula transposed until it was ready to go on dialysis, which may be 2 years or more after the initial one was put in. So that, I think, skews it a little bit. But you can see when the 1-stage unsupported and the 1-stage vascu, they're very close in the time to first use or maturation, even though the veins in the vascu group are much smaller. This is my results with almost 1,400 brachiobasilic transpositions followed out 7 years. And unlike the Swedish registry study that showed that 2-stage transpositions had a higher success rate, my 1-stage transpositions had a much higher success rate. The dotted line is the 2-stage, the solid line is the 1-stage, and then the red line up here is the brachiobasilic. Since it hasn't been commercially available since October of last year, and I didn't start using it till January of this year, we'll focus in on that 1-year timeline, and you can see that the Kaplan-Meier curve for life table survival for the vascular device is as good or better than the 1-stage previously, which was highly selected. And this is about 90% of my current transpositions I do in 1 stages, previously only about 15%. So the vascular device, I think, has benefits doing it on the brachiobasilic. With 1 operation, it protects the swing segment. There's shorter maturation times compared to when I was doing 2 stages, and you can cannulate earlier. Potential benefits, and hopefully my data and others will show that it prevents high flow, which I think will lessen aneurysms and outflow stenosis. And in conclusion, there are 2 devices that are in clinical trials, the self-wrap and velocity, that can be placed at the time of creation, and then the vascular device, which is the only one that's commercially available. And I think there are multiple trials that show improved outcomes, and that it may prevent high flow because the brace and can be used in multiple locations. Thank you.
John, back here, I got a question for you. Huge volume, great tracking of your results. This is really great stuff. For your next 1,000 brachiocephalic fistulas, what % do you think, how many vascus are you going to use?
So I think for brachial-based fistulas, it'll be almost all of them. I think the flow-limiting effect and the improvement in swing segment stenosis warrants use in that. I tend not to use it in snuff box. I don't think there's enough room there for the device. And for really small radiocephalics, I'm not using it because I tend to use a P-slot technique, and you have to use an end-to-side technique in order to place the device.
Alex?
Hey, John, great presentation and amazing data that you're collecting, the number and the quality as well. I will try to bring some controversy in two issues. The first thing, undoubtedly, the device has an advantage of limiting the flow, like a preventive bunding when you're placing it. However, this seems to be a quite complicated and expensive way to induce a preventive bunding. There are other devices like the frame, or you can do it with a suture or whatever else. So the flow reduction part, I think it's an extra, but it's not why we use a device. Now, to the most important and nuanced issue. First of all, you have the Kaplan-Meier curves where you say that your one stage has better results than the two stages. Nonetheless, we know that from what you described, the two stages, you're doing it because the vein is smaller. So we're not comparing the same things. You're comparing better veins to worse veins. So perhaps this is why it might explain it. The other thing I cannot see clearly in your data is the real difference between one stage with vascu and one stage without vascu, because I think in your numbers, the difference was not statistically significant.
You're very correct about those observations. I think the point is that previously only about 15% of my transpositions brachiobasilic were done in one stage, and now it's about 90% are done in one stage. And I think doing it in one stage has earlier maturation, so you can get the catheter out sooner. I think that it also limits the flow, and we know that brachial-based fistulas, at least I spend a lot of time doing bandings of brachial-based fistulas 2, 3, 4 years out, so it's going to be a while before we know if the device is actually efficacious in limiting the flow because of the larger sizes. So yes, it wasn't exactly apples to apples, but the two-stage transpositions, I think, would be equivalent to what I'm doing with the one stage with vascu, because it's almost all of them. So it's 90% versus sort of 85% of all the people that come to my office, as opposed to selecting out just the large veins. Previously for the one stage, I'm using almost all the veins. So it's only if it's 3 millimeters or smaller, or I'm having to do it as a proximal radiocephalic, and then the flow is to the basilic system, so then I do a transposition. So you're correct, but it allows almost all of the brachiobasilic transpositions to be done in one stage rather than the vast majority of them in my hands being done in two stages previously.
So even a 3 millimeter basilic vein, you would do it one stage now?
Yes.
Okay.
Yeah, I always want to commend you. Your data is unbelievable. When I grow up, I want to be like you. You have such a great tracking of all your stuff. If only more people treated access like you do, I think we'd have a better world. One of the questions I got was if we could have a show of hands. I'm going to ask how many people tend to do their basilic veins in one stage versus two stage, just so we have an idea. Can I see a show of hands? One stage? And then two stagers? Wow, okay. That's dramatic. Maybe you've changed practice here.
Well, I think some of the evidence that Carl Illig and a few others showed on their one stage versus two stage made me rethink it, and particularly being able to use the vascu device. I think early on it improves or reduces the rate of the swing segment stenosis that we all get near the anastomosis. And number two, and I hope to be able to show this at a future PVI meeting, that it actually does limit flow long term and limit some of those problems we get with congestive heart failure or outflow stenosis.
Yeah, before Alex says, I always worry when you do the one stage and they come back and somehow it's not working. You're like, oh, I made these very long incisions and it's not working. It's always a sinking feeling. Alex?
Yeah, I just have some difficulty to believe that the vascu is going to change something for a small vein when you do the transposition, because in my impression, perhaps I'm wrong, the problem when you do a first stage, one stage all basilic vein fistula, and your vein is like 3.5, it is just not tolerant. You know, the flow is small, the flow is slow, the vein is small to tolerate the tunneling, perhaps some compression, perhaps some low flow. So I don't see how the vasculature is going to play a considerable role to keep it open for the time it needs to grow bigger, stronger, more flow, and tolerant to whatever might close it down.
So I didn't use a nice picture that Robert said I could use of his, but ultrasound, if you look at the vascular device, there's very little wall thickening within the device. And I think the elimination of wall tension in that just anastomotic segment of the vein is important to avoid stimulating that vein to become thicker in that area. And the other thing is, doing it in one stage, I can make a longer cannulation segment because I can go below the elbow. If I go much below the elbow in a two-stage, you can't wrap the vein up in the segment where you're going to make the anastomosis. You can't have too much redundancy there. But if you do it in one stage, you can get a much more significant length of vein for the transposition. Especially, Mississippi, I think, lost its title this year as the fattest state in the nation, which it held for like 6 years in a row. So we have a large number of patients where we have to do a significant amount of tunneling, as you pointed out, going from deep to superficial to deep again to have enough cannulation segment.
Who's the champion now, Oklahoma?
I think it's West Virginia. I think we lost our
Texas
title.
is
They're close, 3 years.
not far behind. South Africa.
Hi there, James Tunnicliffe from Cape Town. I'm afraid that I make most cynics look like the best optimists in the world, and I cannot understand the enthusiasm for Vascu. We were part of the preclinical trial team. They have a very predictable failure. Totally predictable. They get near-intimal hyperplasia in the vein just at the top end of the protective external stent. And to deal with it is a complete and utter nightmare. It's very expensive for us, certainly, to use. And as you showed in your non-significant difference between the externally supported and the non-externally supported, it makes no difference to maturation. The problem that it creates is difficulties afterwards. And so I would just I would throw a note of caution with the externally supported anastomoses. Carefully constructed anastomoses at the correct angle with adjustment of soft tissue to make sure that the vein sits at the correct angle, I think is going to provide you with the same sort of theoretical advantage that the external wrappings use. And I am a little concerned about cost implications, plus the fact that they have a very predictable failure rate. We've had to go back on 100% of our vascus.
Well.
So I was involved in the trial 5 years ago or so, and we didn't really see that, or I wasn't aware of that as a problem then. And the ones that I've inserted, which is a little over 100 this year, I've seen it in 2, as you described, and we were able to successfully treat those. Now, that's less than a year follow-up, and so I'll hopefully be able to report whether your observations translate to our observations.
So the comebacks will be late. We've seen maybe one in the first 18 months, but the rest will be 2 and 3 years out. And that seems to be part of the problem. And these patients also, because they present with inflow problems, they're often not picked up by the dialysis techs until you hit the problem of occlusion rather than stenosis and poor flow.
Are you talking about radiocephalics or brachiocephalics?
Brachiocephalics. We use them universally for brachiocephalics. We didn't use them for basilics or for the radiocephalics.
Okay. So I try to follow. I've got 5,400 cases I'm following. About 2,700 are still alive, and hopefully I'll be able to report back on that segment that's vascu in a year, because we try to do annual follow-ups on everyone.
I think it's a great idea, but just it seems that the late results have not supported the early results. That's my concern in our hands anyway.
I'll be certain to look at that specific issue.
All right, Robert, we'll give you maybe the last comment on this one.
Maybe to add to that topic, I've been using Vascu for 7 years now, and they are being used exclusively for radiocephalic fistulas. I don't do brachiocephalic fistulas at all because over 80% of our patients in Hamburg have a perforating vein, so we can either do an endovascular AV fistula or a Gratz-type proximal forearm fistula with a perforating vein. So I only used it twice in brachiocephalic fistulas. And we actually published this year over 5 years follow-up on the radiocephalic with over 200 cases and with a comparison group with the radiocephalic in a snuff box group without the vascu, over 140 patients. So occasionally we see that. It's not 100% issue, it's like 1/3 of the patient's issue. And I know that the radiocephalics are a different group than the brachiocephalics, so they should tend to have more problems in the juxta-anastomotic area. And we've actually looked into the juxta-anastomotic stenosis rate, which was around 30%, which included 1 centimeter distance above the vascu too. I deliberately included that area too. And 30%, and we saw that the small size, the size 2, was associated with the highest risk of juxta-anastomotic stenosis, because I think we undersized it when we were measuring in the beginning. We were not dilating the vein and keeping it dilated before measuring it. So then I realized that over the time the 2s kind of disappeared and the rates are not so much high in that group. So I'm not sure whether brachiocephalic has that swing point issue with slight twisting, which then the vascu keeps the vein at the anastomosis angled, and then proximal to it, it turns around to its pocket at the skin. Maybe that might be an issue.
So, Robert, if you're intervening on those, are you just doing angioplasty? Are you stenting them?
100% angioplasty with success of, I think we published it 3 years ago when we had 150 cases at 3 years with success of 96-something%. A couple of them we had to patch because it was advancing into the vascu towards the braid and the brace connection, the neck. So, but most of them you can use a 5 millimeter high pressure balloon and a 6 millimeter DCB. This is my strategy.
Great. Well, Bart, the crowd's woken up.
Yeah, I know. There's a lot of meat on that bone. I think we are seeing no problems with the vascu. We're seeing 1/3 of the patients. We're seeing everybody. So I think there's a lot more to follow on that. With that said, I'd like to introduce a dear friend of mine and a colleague for many, many years, Scott Trotola, who's going to translate the title of his talk, which is Living Your Best Life, Deciding When to Catheter Consign. Scott, tell us what that's all about.
Oh, I'm not going to try and translate that. Consign sounds like such a harsh word. It sounds like condemn, I think. But let's talk a little bit about catheters. I recognize that catheters are not a popular topic. Here are my conflicts of interest. But let's talk about some patients first. So this first patient came up a couple of weeks ago in our practice, an elderly woman with a graft that she'd been using for some 11 years. She'd had fairly few interventions on that axis, but it's clotted now. On exam, it's moderately aneurysmal, but no other real contraindication to declotting except for clot volume. She's got no evidence of infection, no skin breakdown or thinning, no history of centrovenous stenosis. And so the resident scheduled her for a declot. But when we talked about her in rounds the next day, we said, well, why is this patient in the hospital, and what are her comorbidities, and what is, in fact, her ESKD life plan? Well, then we found out that the patient's severely debilitated. She's got COPD, a relative contraindication of declotting. She's demented. Her family does wish to continue dialysis, but she has very limited life expectancy. So I hope you would all agree that we put a TDC in this patient instead of subjecting her to the risks of declotting. This second patient is a personal thing. This was my aunt who began dialysis in the late 1990s. She'd had multiple failed surgeries. In fact, even though I set her up with the best surgeons, all of her axis surgeons failed, or surgeries failed, and interventions on them. And after a couple of years on dialysis, when she was in her mid-50s, she said, I'm not doing this anymore. I want a catheter. So she made a personal choice, and this was in the catheter, the fistula first year, so putting a catheter in was a challenge. And she lived 10 years with that catheter. About once a year, she had it changed for infection or flow problems. She never had a life-threatening infection and died not of catheter complications, but of other causes after 10 years with catheters. So, that's agency. We'll come back to that. So, of course, I turned to the KEDOKI. This is the third day of the meeting. I think this is the first time we've talked about the KEDOKI, so I hope we're not losing relevance here. But they talk about, in every one of their things, they talk about a careful, individualized approach and considering the patient's ESKD life plan. And just to remind everybody that what the life plan is that you're supposed to each year to develop a plan for that patient for each time their access fails. Each time their access fails, you're supposed to reassess that plan and do this at least annually. So they do talk about, in the KDOQI, talk about who should get a catheter. They talk about patients who've had multiple prior failed accesses and maybe don't have usable venous real estate anymore. They talk about whether the access would severely limit quality of life or achievement of their life goals once the patient has been informed of their patient-specific risks. They talk about limited life expectancy, absence of options, and special medical circumstances, whatever that means. So then they have this nice graphic in the KDOQI, and they talk about, who the best choice for that. But the only patient they have is this elderly patient who has no other options. The first consult that I talked to you about. But there have to be others, right? I mean, we can't be just this one old patient. Well, not only the elderly have limited life expectancy, there are certainly others who have limited life expectancy, but want to spend quality time with their family, and certainly putting a catheter in them, regardless of age, is appropriate. Vascular reasons, on the venous side, with all of the tools that we have, the great things that we've seen here at this meeting, that pretty much never happens. But on the arterial side, we've talked about steel some, can still be an indication to go with a catheter, and certainly cardiac issues as well, if a patient can't tolerate the additional work of a graft or a fistula. But we really have to respect personal preference as well, like my Aunt Holly. We really have to think about agency. And then there's also the prolonged use as a bridge. So the patient has expected renal recovery, is taking a little longer than expected, but they're still going to come back, they think, or return to PD taking a little bit longer perhaps. And also, I think we have to ask ourselves, are catheters that bad? And this is really the question of the moment. We continue to refer to very old data showing how catheters are bad. There's never been a randomized trial. There likely never will be. And remember that comorbidities muddy the data. Sicker patients tend to get catheters, and that make catheter data look worse. I'm not here to say catheters are the greatest thing in the world, but they're maybe not as bad as we always think. We also have now a lot of randomized data showing that better catheter care can result in much better outcomes. And so really, when we start talking about catheters, we should be talking about 2026 data and not 1990s data. And then, as we heard yesterday, I really do believe that this stealth catheter is going to come sooner or later. This is a catheter that is invisible to the body and doesn't get stenosis, doesn't get infected. And if we got that, I think we'd all be out of business because we just put a catheter in and that'd be the end of it. So here's just one example of the problems with the data. And this is the authors themselves point this out. So if you look at the upper curve here is we've got well, it doesn't seem to want to work, doesn't matter. The upper curve shows you a difference between less than 65-year-old. The catheter is not that bad compared to a shunt. It's a little worse, but not much worse. But when you get over 65, then the gap is much, much larger. But the authors point out that this is showing an association with increased mortality. It's not showing you that the catheter itself is causing increased mortality. And in fact, if you look here, when they adjust things for those comorbidities, it actually, if you look at the bottom line of each, 1.54 and 1.54 compared to 1, okay, it's higher, but it's not as bad as it looks. And we start looking at these newer interventions here. Well, okay, this is TPA locks. And remember that infection and thrombosis are intertwined, right? So you can see that just giving a small amount of locking with TPA actually dramatically reduces the catheter malfunction rate, and even more dramatically reduces the infection rate. Well, why aren't we all using TPA in every single patient visit? Well, the reason is it's too expensive. This is only done once a week, by the way, in this study. It wasn't done every visit, but we can't even afford to do that. What about antibiotic locks? If you look at all of these studies, the randomized trials, in many of these studies, the treatment group actually reached 0 infections. We can do really, really well. But why don't we use these? Guess what? Because it costs too much. But I think the most important thing here is agency. I want to come back to my Aunt Holly. If a patient wants a catheter and they understand the risks, they should be able to get that. So agency is the ability to make decisions and act independently. And so Ted Saad, who I think really is a really sort of heartfelt way of thinking about these things, and he gave a wonderful talk about this at the CETA meeting a few months ago. And the question is, in his opinion, the answer to who to catheter consign or catheter condemn, if you wish, is an informed patient who tells you that they only want to dialyze with a catheter. And I think we should respect that at all times. Merci et bonne fête.
Thank you, Scott. That's great. I do have a question, and actually it's for Dr. Wasse. you may be one of the few, if not the only nephrologist here in the audience, I'm not sure. But Scott mentioned that the KDOQI recommends an annual ESKD life plan review. Whose responsibility is that? And if it's the nephrologists, are they really doing that or not?
In fact, it is the nephrologists, and they are not doing it, as you might imagine, which is why you asked the question. I mean, I think in the United States, and I imagine in a lot of places in Europe, there's so much fragmentation of care, but particularly the nephrologists don't know that much about dialysis access. They just don't. They don't get that much training. They don't have that much interest, and they really relegate the decisions to the surgeon and the person who does the maintenance. I'm an interventional nephrologist, and so I do the maintenance of the dialysis access, and I have dialysis patients. It is the responsibility of the nephrologists, and that's not something that they do. They, in most cases, it's not an area of interest. It's not an education piece in their training, and it's unfortunate. And despite multiple attempts to try to incorporate it with our national societies and having multiple meetings a year in the U.S. and here in Europe that many of us attend, there's just a limited interest. And I'd be curious for the audience. This is supposed to be interactive. How many of you surgeons, because this is predominantly surgeons, how many of you have conversations with your nephrologists about the dialysis access that you plan to put in to your... Okay, that's great. That doesn't happen in the United States. And do they ever push back on your plan? Do they ever have an alternative? A few. Okay. All right. Well, you're doing far better than we are in the U.S. I'm heartened by that.
John?
Great presentation, Scott. Tell me, on the ones that are going to be catheter dependent, do you have a plan to regularly replace that catheter at 1 or 2 year intervals? And in the ones that have infection or suspected infection, are you going to replace it through the same tunnel? You can go to the other side. You're going to try to stay on the same side to avoid both sides being thrombosed.
Infection without sepsis is always best managed by over-the-wire exchange. There's good data on that, and I think we're pretty much, although the most recent KDOQI backed off on that a little bit, quite frankly, that's the standard. And I think, if you really sort of take good care of catheters, and in doing so, you're also taking good care of your venous real estate, because if you keep churning sites, then obviously you're churning potential access sites in the future, and we want to leave all you fine vascular surgeons with plenty of material to work with, right? So we don't regularly exchange, and I'll tell you that, you'd be surprised at how well some people do. I had a third example in there. I took it out in the interest of time, but there was a patient I saw just a week ago who came in. Her catheter had fallen out, but this catheter had been in for 3 years. I don't know why it fell out. It'd never been exchanged over the wire. It just up and fell out after 3 years. But she was a patient who had type 1 diabetes. She was 60 years old. She had a failed kidney panc, and she was awaiting the next transplant. And she said, I like my catheter. I've never had any problem. Would you please put another catheter in? And that's what we did. So again, agency, she understands the risk. So I don't change them regularly.
So Dirk Henschel says that in a number of patients, those that have it over 2 years, it develops such a dense sheath that is maybe very difficult to take out. So he has a routine of replacing them around the 2 year mark. Has that been your experience?
Now, I'll tell you something, and we actually, I just generated some data on this not long ago, looking at catheters that have been in for over 2 years and over 1 year, over 2 years, and we really didn't have any difference in the outcomes. And if you do have a catheter, the stuck catheter does happen occasionally. Managing that with the intracatheter angioplasty technique works pretty much in everybody. So if that happens, we just do that, and it works great.
So, and what's your practice when somebody comes in? Because most of it is degeneration. If I exchange catheters that have been in for 2 or 3 years, most of those people have an experience where either the Luer lock got crimped, or it broke, or the distal port, degenerated. Do you then exchange the entire catheter, or do you just do a replacement part?
So if the catheter has a replacement device associated with it. Some do and some don't. The ones that we do. And we, if the clamp's broken or whatever, or the hub's broken, we just replace the hub. We leave the catheter in place. I think once somebody has established a catheter and it's working well and they're not having problems, they tend to do very well. You get over a certain hump, and you know this. You see it all the time, right? You get people over a certain point, and then all of a sudden they sail. And then they just keep doing really well. And so the last thing I want to do is mess with that, right? I mean, it isn't broken. I'm not going to fix it.
That's great. I do have a question for the audience. KDOQI is the U.S. guidelines, but there are many guidelines in different countries. I wonder, we have a lot of surgeons here. How many people have actually spent time, sat down, and looked at whatever your country's guidelines or the KDOQI guidelines? Hands?
And do you follow them?
Do you follow them? That'd be the next question. But I'm not going to push you any further on that. Were there any other questions?
I think Alex had one.
Alex?
Hey, Scott. So great presentation and very good arguments, but I will reverse the question and the subject. I don't think it's difficult to accept the reasoning of a patient who says, I have my catheter, it's there for 2 years, I had no problems, don't touch me. Obviously, you're not going to touch him. But what if you have the patient, 83 years old, he's coming and he's asking for a fistula. The nephrologist, he's asking for a fistula because it's better for his financial and his unit. Everybody's asking for a fistula. But when you see the patient, you say, well, he's better off without a fistula. What are your criteria to decide where you're going to give a fistula or not? And what are your arguments going to be? And are you going to push back?
That's a spectacular question to which obviously I don't have the best answer. First of all, I'm not a surgeon, so I'm not necessarily having that conversation, but often I'm having the conversation about the catheter. Somebody's coming in for a catheter, and pretty much everybody, I'm trying to convince them to make sure they go see the surgeon to get a more permanent access created, because most people are going to be better with a permanent access. If you have the patient in question that you're describing, again, if that patient really understands things and is willing to accept the fact that they may have to have some additional interventions done, or they may have to have some maintenance done on that access, and they're fine with that, and their heart's working well, and they can tolerate a fistula, then they should get a fistula. This is the topic I was assigned, right? So, I'm being, trying to defend things, but I think we all agree that catheters are the least good. Even when you account for the comorbidities, right? The catheters are the least best option among the options that are out there. But we have a load of people out there, like that patient that I was talking about, who has dementia and doesn't even know what's going on. The family's the only thing keeping her on dialysis, who really, I don't think you want me to send that person to you for access.
No, yeah, but I understand. The thing is that medicine, as everything, has become kind of industrialized, and we're dealing with patients as if it is our product. And I think it becomes obvious if you do this as long and as much as we do it, that we are doing way too many fistulas and procedures for patients that we should probably just let them be, because patients, you send them to get a fistula, 90% of the time they say, okay, doctor, I'll do whatever you tell me. And you end up operating them 5-6 times while you could just leave him with a catheter for 2 years, and that's not good.
Well, I think, as I said, if we take all of the modern tools that we have and all the techniques, and if we're spending a lot of money on the access surgery, why not spend that money on the TPA lock or on an antibiotic lock or whatever? If we really sort of think about this, and again, I wish you could hear Ted Zod's talk. I don't know, maybe if the CETA talks are available online. He really made this incredible point that, at least in the United States, there's a financial incentive to convince the patient to get access, right? So that means that we're not necessarily putting the patient at their patient's interests at foremost, rather, because there's this financial incentive or disincentive if you have a catheter in place. And yet, some people are going to do well with catheters, 100%.
Well, that was excellent. Thank you very much. I think it always brings back the point that the right access for the right patient at the right time. So whenever we think we're going to be replaced with algorithms, it turns out you actually need to look at each specific one. So a speaker that needs very little introduction is Dr. Robert Cheverdian, and he's going to give us 2 talks. And we'll start off with the first one with Heidi, right? Heidi.
Thank you, Stephen.
Heidi, whatever.
Good morning, everyone.
After that first one, we'll do questions, and then we'll let you do your second one.
Perfect. This is my first time here on this catwalk, so Stephen told me you have to walk like a Chanel model towards the screen. So I said, naturally, I do it all the time.
You do have the Gucci shoes, I would like to point out.
Yes.
So you can walk those up and down.
So it's good there is a screen here because I'm blind, so I will not see what's happening there. So here are my disclosures, and first of all, I would like to thank the organizers for inviting me, and I know how difficult it was to get me on this catwalk because Moni didn't want me to have here. I don't know. I think I know why, because who wants to have this guy on stage, right, on this catwalk? But in reality, I looked and I saw that I think she wanted this to be a completely United States session, so a little did she know. And jokes aside, thank you for having me, both of you, and also for the organizers. And for those of you who don't know what Heidi is, this is not the Heidi that you're thinking about, and some of you might know her from her Halloween costume parties, like this one. Crazy. But this is actually the Heidi we're talking about. Or Heidi, I don't know. You know it better, right? Heidi, whatever it is. Ischemia. So one thing that we need to start is, of course, we need to differentiate whether there is actually still or there are some other reasons behind the complaints that the patient have, and Larry Sher has this nice article about it. But there are some risk factors affecting the risk of ischemia, which would be diabetes, peripheral arterial disease, female gender, and brachial artery inflow is associated with higher risk of HIDE. And this is a complication which can lead to pain, severe ischemia, loss of tissue and hand function or extremity function, and the incidence is reported to be 8 to 20%. So there are 4 stages of HIDE that we know about, and this is similar to PAD if you consider the Fontaine classification, if you use it. That you don't usually treat stage 1, you treat the stage 2 if the symptoms are severe, and you treat stage 3 and stage 4 because of the pain, rest pain, and the loss of the extremity risk. And there are several surgical techniques which you probably hear since 1996. They haven't been really changed much. It's Rudy, it's drill, it's drawl, it's prowl, it's pie, it's bending. So I'm going to pivot a little bit from those things that you have been hearing all the time. And one thing that we need to think about is if the extremity is endangered, really endangered, we need to consider ligating the axis immediately. And before moving forward, I think that prophylaxis is always better than the treatment, or than struggling to choose which treatment is better. Some might say, I prefer drill. Some might say, I prefer pie. Some might say, I do amazing distalizations and bandings. But if you have low flow and still that doesn't work, etc., etc. So with prophylaxis, I'm going to brag about it a little bit, because in Hamburg, which is the second largest city in Germany, we have managed to establish a program that almost half of our patients are getting an access in a preemptive stage, and almost 50% are getting a radiocephalic fistula in some form, whether it's a snuff box fistula or whether it's a wrist or mid-forearm fistula. And then we add to that also the endovascular fistulas and the proximal forearm radial artery-based Gratz-type fistulas with a perforating vein or a branch. So almost 80% of our patients have a forearm artery-based fistula, which already reducing the risk. And from over 500 forearm fistulas, we had 0 cases of still. So my presentation is based on pure theory rather than practice, because we barely get patients with still. Most of them are brachial artery-based, brachiocephalic fistulas. Some from, nobody comes from my center. All are from other surgeons, of course. So I think one thing that we need to talk about is the artery. Maybe we need to concentrate on the arterial inflow more when we have patients with still, and then we perform angiogram. In most of those patients, without compression, we see no vessels, and we perform it repeated with compression of the fistula of the axis to see whether there is a perfusion there. And then we have this finger brachial index, which we can perform and see how it looks on the axis side with and without compression.
But then we ask the question, can we use the balloon angioplasty and ask our interventional friends, Scott and Bart, to interfere and increase the inflow to the arm after we considered all the surgical options? And there have been some trials, some publications on this, although not many of them are based on treating ischemia rather than just treating forearm radial artery or ulnar artery pathologies. And you see that the risks are higher, 17% of rupture, primary patency at 12 and 24 months, around 60%. And Scott has this paper, 20 years experience. Scott is there, not there. This is Bart, this is Scott. And they actually showed that, I need to get closer to be able to see what I actually have here. So they had two groups with which were referred to within the 20 years with the assumption they have still, and in half of the patients, barely half of them, they did no treatment, just diagnostic fistulography, and in another half with intervention. And when you see the numbers at the bottom, I got to figure out how this pointer works. You need to hold it and keep it, and then figure out which direction. Yeah. Ooh. So half of them actually had experienced improvement of the symptoms, and the other half didn't. So it doesn't look like this works. So I decided to, again, to pivot a little bit to possible modern strategies. One would be the lithotripsy, IVL, and the one would be the Botox. And the interesting thing is that both of them were presented recently at the VITH symposium on different topics at the same session. And with the IVL, have no practice with it, and it's off-label use for upper arm extremities, for upper extremities. There was an abstract actually submitted from the group, Italian and Canadian group, which have been treating the radial artery for forearm fistulas. Again, not steel, but just to improve the maturation rates. And they also published it from 2004, they had the fistulas included in the group, and they seem to have good results. And the presentation from Dr. Rushinsky at VITH Symposium from St. Louis was also showing how they treat with IVL the radial artery to improve the flow through the radial artery in the fistula. And they had limited patients, but they still all had patients that they were treating, singular patients, and John Urini also does, to treat the steel with calcified arteries. And the second one was Botox, which I was really surprised by, because I had a case of steel presented at CETA, and Larry Sher stood up and said, "Why didn't you use Botox? Because we do it in New York." And so his colleague presented it at VITH, and basically the idea behind it, the rationale is that it will inhibit the acetylcholine release in sympathetic terminals. And if you have patients where you already considered all the possible surgical options, or they didn't work, and you did an angioplasty or IVL or whatever, and it didn't work, but you still want to keep that extremity and access running, you can try the Botox. And they actually used 100 units of Botox with 10 units per neurovascular bundle per finger. And then eventually, in 4 patients, 3 actually had marked improvement in pain and perfusion with ulcer healing, and 1 had mild improvement. Not much data, but I thought that would be interesting to add to the already very old and known topic of struggles, how to treat steel. And to conclude, we know that especially for the brachial artery-based fistulas, if you stay distal and don't go high, like you mentioned in your talk, towards the axilla, the risk of HIDE remains a problem, and management must be individualized, tailored to both patients, patient factors, and access configuration. There are different surgical versions of what we can do. If you have high flow, reduce the flow, distalize it, drill, PI, Rudy, and ligation, of course, because extremity has more importance than the vascular access, and patient safety, of course. Angiography, if you have good ultrasound skills, but you will not be able really to see the subclavian artery, remains obsolete, that we need to do it, and the treatment combines probably the older versions. And maybe if we have these newer technologies showing better outcomes in our patients, a combination of both. So after we had some drinks yesterday, we became friends again, so I think Moni will invite me next year. Maybe not, we'll see, and thank you very much.
Thank you. That was great, Robert. Alex?
Well, Robert, congratulations for the presentation. I have no problem with Botox. Actually, I'm thinking about getting some Botox myself at some point. But to start having discussions about Botox in patients with fistula and ischemic problems, I find this problematic. And why do I say that? I've been dealing with lots of Heide cases because we are like a tertiary center for these patients. Basically, almost half of them from the Paris region come to us. And I don't remember any patient that you cannot adequately treat their Heide problem with the appropriate operation being either balloon angioplasty of a central arterial stenosis, if it's an inflow of the artery problem, and if it's a distal artery disease problem, meaning that they have a fistula with a severe arteriopathy of the forearm arteries, you just need to do a good proximalization from a healthy proximal artery. So what I suspect is that people without adequate training or good technical solutions are trying to find weird solutions for a problem that we have the right solutions.
I totally agree with you. The intent was to make this presentation a little bit more modern rather than stick to the 100-year-old surgeries. But I think that patients with combination of maybe type 1 diabetes, severe forearm disease, that you've done the central artery, you've tried the balloon angioplasty of the radial artery, you did the PI with your, maybe even using the native vein, the basilic vein and cephalic vein to avoid graft. There are still some patients which might have the ulcer or the necrosis. Those would be the very, 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 very limited patients that you could consider it. But I agree that the surgical options and the endovascular management nowadays basically avoids all of those new things.
All right, Scott?
Robert, great talk. Thanks for showing that paper. I would like to take a sort of a glasses half full approach to the results. What that shows, and that's all comers, right? There's people with bad diffuse disease and focal inflow diseases. Obviously, we do better if somebody's got just a focal subclavian artery stenosis, right? But in an all comers approach, we're able to make almost half of them better without having to do it surgical. And then if that doesn't work, we've got the surgical options, which, as we just pointed out, work very well as well. So I do think that there is something to offer percutaneously. We have been using IVL as well. We've got an abstract at the SIR meeting about it. And it definitely, for those really bad long forearm lesions, it definitely improves the results, but it's also not a panacea.
Yeah. I think you should combine both surgical and endovascular skills.
There's also a big problem, and it's also a reason why surgeons must go in the dialysis unit and discuss with the nephrologist. We see these patients very late. They are complaining of their hand since months, and it's frequently the case to see this patient very late. And sometimes they spend some time in orthopedic departments, and that's to be made later after surgery, vascular surgery.
Totally agree, Thierry.
John?
Great presentation, Robert. I'm surprised that you don't have any steel. About 75% of my practice is radial-based, not quite as high as yours, but I see a number of patients who complain of their hands being cold when they're at or hurting at dialysis, the endodialysis, and almost all the radiocephalic fistulas have retrograde radial artery flow if they have a patent palmar arch. And so if you can compress the distal radial artery and verify that the ulnar artery and digital radial artery flow goes from monophasic to biphasic or even triphasic, then ligation of the distal radial artery is an easy thing to do to prevent that or alleviate that symptom.
Yeah, like you mentioned, we see in the ultrasound in over 80% retrograde flow in the radial artery, but I think that maybe Germans have good palmar arch, so the ulnar is enough to support it.
Question from Cape Town?
Yeah, so I enjoyed that talk immensely. The real problem patients for us are the ones who, like the photograph you showed, with ulceration or digital gangrene. And in the small subset of patients who've actually not got high flow fistulae, brachiocephalic, who have basically a steel with ischemia, and you can't do anything to improve the circulation into the hand, thoracoscopic sympathectomy is a very good option. even for diabetic patients who are supposedly sympathectomized already. So that's one to think of.
Thank you.
It also may be a little bit longer lasting than the Botox, having to redose that. Any other questions? Well, great. Robert, we've got one more.
No, I don't want to abuse. If we're off time, you can.
No, we've got plenty of time.
Okay, so a couple of things. Again, to insist for this sympathectomy and Botox and anything, if you do a proximalization high from the subclavian artery, from a big healthy artery, hemodynamically for the arm, for the hand, is as if you don't have a fistula anymore. Because the Still syndrome is a question of pressures. It's not a true Still syndrome. True Still syndrome with ulcers is a patient with severe arteriopathy, and you're adding a drop pressure because of the fistula. So if you do the anastomosis high, you don't have this issue anymore. Very briefly, for the radiocephalic fistulas, I think we shouldn't forget the danger of having a true Still syndrome in a patient who is radial dominant. And I do agree with you, John, and these are the patients who have problems that we consider, well, it's a semino, let's do a semino, everything is okay. And when he has a Still syndrome, we realize that he only had a radial artery and his ulnar is occluded or minimal or non-existing. And we did a big, beautiful anastomosis to make it mature, and it's the equivalent of having a brachiocephalic fistula with a 2 centimeter anastomosis. So it's not because it's semino, it's safe.
Excellent point. Robert, take it away for the final presentation in the morning, and we'll have a little time for a question after that, and appreciate everybody's attention.
Thank you. Let's wait until it starts. So this presentation was moved last minute to the spot, so I tried to modify it a little bit. Yeah, the title is very confusing. So in case you don't know what the hell KEMIC is, AI will show you this picture. And I think this looks better than this picture of the fistula from AI. I don't know what kind of fistula it is, but luckily our patients don't have this anatomy. So I'll start briefly with the introduction of this case. 57-year-old female patient. She has a radial artery-based proximal forearm surgical fistula, 5.5 years old. 6 previous interventions, including 3 thromboses and cephalic arch stent graft for the stenosis in 21, which was treated twice due to edge stenosis in 22 and 23, and she presented with thrombosed axis in January 24. So after thrombectomy, this is the angiogram, intraoperative angiogram, showing you the severe edge stenosis at the central end of the stent graft, light stenosis at the peripheral end of this stent graft. So what would you typically do? You would do an angioplasty using different types of balloons, maybe DCB, no real data in edge stenosis, maybe reline it or extend the stent graft if you want to go more central and occlude that axillary vein. Maybe you want to do a bypass because the turn down is probably not possible anymore, it's short. Or one thing which is funny that I once saw on Twitter back then, or X, somebody said, remove the stent graft and the first rib and then patch that cephalic arch. And I said, I'll call you to do it because I'm not doing it. So in average, we know that we have challenges with our dialysis access fistula grafts. We have patients who require interventions. We have unassisted maturation rates of 40%. We graft venous anastomosis in AV grafts and cephalic arch in brachiocephalic fistulas being the weak points. And in average, depending on AV fistulas or grafts, we have here around 3.3 interventions per year according to literature. And another paper from Scott's Center, really nice, everyone loves it. The factors affecting the risk of stenosis in AV fistula are different and complex, and depending on which type of access you have, the juxta anastomotic in forearm, the swing point in basilic, transposed basilic veins, cephalic arch, or graft venous anastomosis might have the higher risk incidence of stenosis. So the balloon angioplasty became gold standard after being introduced in '74. And it showed pretty similar results to the surgical revisions of the stenosis. And again, in that same paper, they showed an algorithm how to treat a stenosis, whether there is a significant recurrent residual stenosis or not, how to do stepwise. Very nice algorithm shown in that paper. But what we know is that when we use balloon angioplasty in our stenosis in the AV axis, we can rupture the neointimal layer, and we treat also the healthy segment of the vein outside of the stenosis and damage that. We have then limited success due to elastic recoil or some cases of resistant hyperplasia, although nowadays with Conquest 40 balloon we can crack every type of lesion. But it is associated with a risk of 2 to 7% of complications, including hematoma and that tear, especially in the weak segments like cephalic arch, which tends to recur and have more difficult reintervention situation and graft venous anastomosis. So the literature shows that for a primary patency, sorry, a little bit busy, but you can see here primary patency, target lesion primary patency rates after angioplasty, even if you use drug-coated balloons at 1 year, could be better than we actually expect. So we have these adjunctive tools added. Also, we've learned from the impact trial or DCB trials that the proper vessel preparation definitely plays a huge role in the interventions, ultra-high pressure, scoring balloons, cutting balloons, DCBs or stent grafts, endoprosthesis, and then this KEMIC technology which recently came out, which is basically that you don't want to apply high pressure and create an explosive trauma to your lesion, rather than create micro-incisions like if you would use scalpel and create incisions on your inner layer of your lesion to be able to then make that lesion more compliable to the angioplasty. And this is what this flex vessel preparation device is intended to do. This is a device which goes over the wire. It's not a balloon, it's just a device with 3 struts, and those 3 struts have 3 surgical microblades at 3 positions, which when you advance through the lesion, and I will show you, 6 French sheath, 014 or 018 wire, and 3 lengths. It is approved for access and also for PAD, which when you pass through your lesion 4 times, when you pass, pull back, create incisions, close, pass, rotate, and when you've rotated 3 to 4 times, you have 9 to 12 circular micro-incisions prior to your angioplasty. You can lyse the valves there if there are valves and treat the neointimal hyperplasia. And you can see here as an example in an ultrasound, which I found fascinating when I did the first cases, that when you deploy the flex across the lesion, you see the stasis because it's occlusive due to the severe stenosis. You see how the blades attach to this first stenosis and then the second stenosis. There are 2 stenoses. And already after the first pass, when you introduce the device through these lesions, the stasis disappear, meaning that there is already some kind of lumen after the first pass. And when you do it 4 times, you can see here that the blades are barely being compressed by that lesion, especially the proximal one, because they already treated it without applying pressure. There is less than 1 atmosphere pressure from those blades. And why would I use it? There was a little bit data coming from John Rooney from US, which showed benefit specifically in cephalic arch, and also Ari Kramer showed it from AV registry, Flex AV registry from United States, from several centers, that they had benefited, and they've published it actually in Journal of Vascular Surgery in November. So I started to use it back in the early 23 and 24, and then eventually we had 3 groups that we had with high pressure balloon, with scoring balloon, and with a flex vessel preparation group. And in order to also improve the effect of the vessel preparation, my thought was that it will not just protect the lesion from the explosion that we will create with our high pressure balloon, but also when we use the drug coating balloon, it will probably increase the effect of application circumferentially of that drug from your PCB, whether it's paclitaxel or whether it's sirolimus, which is still debatable whether it works good in access, to treat it. So all 3 groups of those groups had DCB included in their treatment. And the groups were pretty similar. You see here that we have 175 cases treated with 71, 47, and 57 patients. And one thing which was significantly different was that the flex vessel preparation group had the highest previous interventions on their axes. So the ones who had higher interventions tend to have more interventions, right? So we saw that the target lesion patency rates at 6 months and then 12 months were higher in the vessel prep group, but we didn't reach statistical significance due to the dilution at the end of the trial, not so many patients. But one thing which was obvious that we saw is that after treating the lesion, the reintervention rates per patient year were the lowest in the vessel preparation group. So the signal that they had more interventions before, but less interventions after, kind of showed me that it seems that it actually works not intentionally during the procedure itself, but also later on. And this is something that I recognized later on. More patients had actually juxta-anastomotic stenosis in the POBA group. And when I looked into some studies, especially some from Japan, we saw that the juxta-anastomotic lesions actually tend to have better outcomes being treated by DCB. So again, it flips that higher juxta-anastomotic treated with DCB in the POBA group still had worse outcomes. So what are the possible cost implications? And this is what we're working now and writing down the paper that we looked into 2 groups from the United States and from Germany that we matched to the balloon angioplasty groups and looked into the interventions and into the possible costs, is that based on the reinterventions after the procedure, we would be able to save approximately, this is still preliminary data, around 2,500 euros and $2,600 per year per patient. So if we treat 100 patients, we save around 250,000 per year. So to conclude, we see that in real world, the combination of DCB and the vessel prep device trends to improve outcomes, and we have reduction of reinterventions, and proper vessel preparation leads to longer freedom from target lesion revascularization, especially at cephalic arch, and also graft venous anastomotic stenosis. And back to the case that I presented you at the beginning, this patient actually, again, presented with a thrombosed axis, 2 reinterventions due to edge stenosis in January 2024. And what we did, sorry, I skipped it. Let's see whether I can start the video again. Yeah. So this was the initial angiogram after the thrombectomy of this axis. I prefer surgical thrombectomy. I'm a surgeon, but I do endovascular procedures. So Fogarty balloon thrombectomy angiogram, 4 passes with a flex. This is cephalic arch that was difficult to see in ultrasound. That's why I used it under fluoro. Those calls are in a small arterial branch. She had bleeding several years ago, which were called from a branch of some chest artery. And then after passing this with a flex, we used the balloon, the DCB, and 4 passes, 8 millimeter high pressure balloon and 8 millimeter impact DCB with 1.1 liter flow. And since then, the patient didn't have any reinterventions yet, with last follow-up flow of 850. So where should we use it? I don't know yet. Edge stenosis, graft venous anastomosis stenosis, cephalic arch stenosis. Still, the weak points might benefit the most, but we'll have time to figure out, sit down and think about it when we have more patients, more data, and the company actually initiating a randomized control trial in the United States for cephalic arch stenosis. Thank you.
Well, excellent. I know we're bumping up against time. Alex?
Okay, so scientifically, I understand the premise and I understand the reasoning of the device. I have a more pragmatic question. Okay, so and perhaps I'll give you some insight in the subject to the audience, perhaps in the subject of the startup companies and some of the problems we have here in Europe when we want to use innovation. So these companies, of course, when they are created, they want to be acquired by a big company and have some value. Therefore, the price of the device is often quite expensive. When I spoke with this company, because I wanted to use it, and Robert, please give me some clarity in this. I believe this is the cost of a device is in the thousands of euros, 2,000 or 3,000 euros. That was
1,400.
1,400, exactly. And in a Paris hospital, what we get to create a fistula as a whole is 1,300 euros. So the problem is that the prices of these devices, while they make sense for the United States situation, which is quite, expensive to treat a patient, the hospitals get more money. For us in Europe, it's quite problematic, and that's why I have difficulties adapting innovative devices in a Parisian French hospital or a European hospital. How do you manage to go around this problem in Germany?
So this is a valid point, and we have the same issue with the endo AVFs, right? I mean, you put 4,000 or 5,000 in the procedure, and then try to figure out whether it's at least cost beneficial or patient beneficial down the road. And in Germany, we have a code not only for balloon angioplasty, but also for blade angioplasty, which folds the device into scoring devices, cutting devices, and this device fall into the blade angioplasty, which gives you more reimbursement for the procedure. So at the end, you come around the same reimbursement that you can pay 1,400 for the device. This is one point which gives you the chance to use the device. Another thing which doesn't affect this device but affects endo AVFs in Germany is the NUB, which is a specific code for novel innovative devices, which we have in Germany for those types of devices. Like HeroGraft, Viaban also have those. Viaban, novel, 15 years, it still has that. But the other thing is that I think that you don't have to see it. You need to prove it, of course, somehow, but you shouldn't see it as investment during the first procedure with higher costs, but what does it benefit to your healthcare system after a year from those patients?
Yeah, it's a good point, but let me push back on something. When you talk about ellipsis, HeroGraft, inside out, like this type of innovations, you're really adding something significant there, making things different. For example, endo AVF, you're creating an anastomosis, a new fistula, replacing a surgery. Here, we're talking about taking a problematic fistula and trying to find a way to prolong his life a bit, instead of doing a Kinetic balloon or high pressure or a DCB, but you're not adding 50 euros or 100 euros. You're adding like a huge amount, like more expensive than a graft.
But if you're saving after that, then you're still saving.
How are you going to save 1,400 euros?
If you perform one reintervention instead of 4, you're saving.
You think it's going to be so transformative?
It's just a number. I don't know whether it will improve from 4 to 1 or from 10 to 3. But this is, if you don't do it, if you don't have data, you cannot prove it. So unless you have data to show it, you cannot show it. And if you have data, you analyze it and you show it. And if it doesn't show the benefit, then you can discuss the point, why should I pay 1,500 if it doesn't benefit? But if you show that it can reduce the interventions from 6 to 2, if you reduce the stent graft deployment in cephalic arch or in graft venous anastomosis, which adds you another 2, 3, 4,000, you benefit. We showed that we had one stent graft in this whole group being used as a bailout. So those are the things that we will have to look into, but if you show less interventions, less expensive stent grafts, then you benefit, or your healthcare system benefits.
Well, Bart, I sense a debate for next year.
Yeah, there's even more meat on this bone.
Yeah,
so,
some economics.
Lots to go over.
Well, first of all, thank you to everybody for attention this morning. Everybody can get a coffee break or something like that. And then, of course, we have an exciting aortic session coming up next. So PVI never fails to deliver. Lots of stuff going on. Thank you, everybody.
Thank you. Efkaristo. Parakalo.
Yes, merci beaucoup.